cataract. So whenever you're dealing with a subluxated cataract, the aim of course is to preserve the capsular bag and put an IOL in the bag to minimize vitreous loss and risk of future retinal problems and glaucoma. The key of course is to be prepared. A very useful sign on the slit lamp is to look for increased iridolenticular distance, because if there is an increased space between the iris and the lens, that often points to an area of zonular loss. Also important to note is the etiology. If you're dealing with a non-progressive zonular loss, you're likely to have a better outcome and you may not need to fix the bag. But if it is a progressive zonular loss, even if you have a limited area of subluxation at that time, intraoperatively and post-operatively that may extend. So it is wise to fix the bag through a scleral fixation of either the ring segment or the IOL itself. So first I'll be showing you a case which is being done manually. The incision has to be made in an area away from the site of zonular loss. The rhexis is initiated in the area of intact zonules. You must take these patients under a peribulbar block, avoid the use of intracameral lignocaine, do hydrodissection in gentle multiple squirts. This is the endocapsular ring placement. This is a PMMA open flexible loop that comes in various sizes, 10, 11 and 12. Now this is the PMMA a segment of the endocapsular ring loaded into an injector and then put into the capsular bag. You must note that the time to put the ECR is as early as needed and as late as possible. Why am I putting it in early is because once this segment is in place, it will centralize the bag. It will give you a counter traction to all your maneuvers of phaco emulsification. It will prevent vitreous herniation. So this is the phaco emulsification. Remember, you have to start from the periphery, and by the time you're in the center, you should be deeply buried. This is a very hard cataract. Direct chop is the best way to minimize your stress on zonules. So we are going in and chopping. This has to be slow motion phaco. Try and use more phaco power. If you're using less phaco power, you will induce a drag and unnecessary traction. So more phaco power but slow motion phaco. You can use a higher phaco power. If and ever vitreous surfaces, you must deal with it then and there, because vitreous will plug your phaco probe, because phaco cannot emulsify the collagen. It can only suck out the hyaluronic acid. So you must recognize vitreous as and when it appears. You see how difficult it is to deal with a leathery cataract. You see the bag moving. Fortunately, this is a diabetic patient, but it's a traumatic subluxation and the other zonules are holding on. But this seems very tricky, and it's taking me a lot of effort to emulsify each piece, break each piece and put it into the phaco handpiece, because it is a subluxated hard cataract. Please remember, when you're emulsifying the last piece, you must be very careful, because this capsular bag sometimes becomes folded or may face up. So you have to put in viscodispersive before taking out the last piece. Fill it with viscoelastic. This is a little tricky bit because the ECR is in place. So when you're doing IA, it is a little difficult. So you have to tangentially strip the cortex and then pull it centripetally, because the cortex gets entrapped in the endocapsular ring. After this, you simply go in and dunk the IOL in place. You can put in a single piece IOL in the bag. Why? The reason we are putting a 3-piece IOL is because the haptics of the 3-piece IOL give added support if aligned in the area of subluxation. Also, if you a lot of people recommend that you can put a 3-piece IOL in the sulcus also, but we prefer putting it in the bag. If the bag sublux further, which may happen in some cases, fortunately not in most, you can actually glue the same 3-piece IOL in position. Now, so this is how we handle it conventionally. I'll now be showing you a case which is as difficult, or rather more difficult, because this is nearly 180 degrees of subluxation. 44-year-old non-diabetic. He was a doctor, and this is being planned. This is the pre-op, and we are taking this patient up with a Femto procedure. Now, the Femto gives you the ability to create a perfect capsular rhexis and also do a nucleotomy. Capsular rhexis is the most important step for a subluxated cataract because it is difficult to do And if you don't have an intact capsular rhexis, you can't place an endocapsular ring. So this is the patient interface which has been latched on to the eye, and then you get an overlay. You see here the overlay is visible. You can see the tilt on the OCT. The capsulotomy should not be centered on the pupil or the limbus, because you want the capsulotomy centered on the lens, which may be tilted. So this is what we are trying to do. There is a scanned capsule center setting in the laser, but when we use it, it reduces the size of the capsulotomy to only 4.5, because you cannot have a capsulotomy too close to the iris. If the femto hits the iris, it causes bleed. So now we are using a customized setting where you can drag the capsulotomy and place it as centrally as you can without compromising the size. So this is a nearly 5 mm rhexis. The rhexis is over in a few seconds, about 2 seconds. Then the nucleotomy is done. So this is the end of this is how the patient looks under the table. The reason we are putting a pars plana vitrector is because we have stained here with tricot and found there's a lot of vitreous. So vitreous, if it is present, you cannot start phaco. This is actually this subluxation is worse than the previous one I showed you. If you're going through the pars plana, it pulls the vitreous back, and that is really bringing it home rather than go anteriorly. Now what we are doing is just removing the capsulotomy, which is pre-cut, again putting in the endocapsular ring. See, this subluxation is worse than the one I had shown you, and now look at the ease with which the nucleus is just chopping. It is a pre-chopped nucleus, so you are not going to extend this subluxation, and the phaco is very, very easily done. Even though this is a case which was worse and you had vitreous pre-operatively also coming out. Removing the vitreous was important for two things. One is that you have obviously made your phaco much safer. Second is that you do not get much upthrust. If you've not removed the vitreous and you're constantly hydrating it, you will get an upthrust which will make your phaco much, much more difficult. Bimanual IA is usually done. I do bimanual in all cases of femto, because cortical aspiration is a little different in femto because you don't have frills of the cortex to latch onto. So this is in subluxated cataracts or any complicated cases. Do remember, you don't want to decompress the AC. So when you're taking out your instruments, fill in viscoelastic. You don't want any additional fluctuations in the AC. What we have here is now a well-centered IOL. However, we must remove all strands of the vitreous, and just observe closely. You will have to use triamcinolone, which you should use in all cases where vitreous surfaces, and this is a small strand which you would not have seen had you not used triamcinolone, and this strand would have caused unnecessary traction and post-operative complications. So we have identified the strand, and therefore we will have to do a vitrectomy to remove it. So this is how the patient looked post-operatively. So this technique really combined a combination of femto and vitreous decompression. I'll just highlight the fact that though femto is a beautiful technology, you must understand it. It's not that it comes without complications. Sometimes you have capsular tags. It's a beautifully done capsulotomy, but there may be skip areas. This is not an issue, but you must pull these areas centripetally. Pull it towards the center. If you just pull it anywhere, it will cause a capsular extension and lead to a PCR. This is a white cataract. A white cataract really is easy to phacoemulsify if you get a good decent sized rhexis which is continuous. So this is a white cataract being taken up for a femto procedure. I think this is a white. No. You see here there is a gush of fluid, right? So this was a high intralenticular pressure which causes the once released, you see this liquefied cortex coming out. So this is what almost a case of phacomorphic glaucoma with a very intumescent lens, which would have ripped apart and given you an Argentinian flag sign. But here what we have is that the capsulotomy is nearly done, but there may be skip areas. So you have to pull centripetally, and you will always have a good rhexis. And you can see that there's a nucleotomy also which has been partially done, because there's a white cataract is a slight barrier, but it's very easy to handle these complex cases. and you will be getting great results with the Femto technology. Now this is a patient who has a pre-existing rent. This is a posterior polar cataract. You can see a vertical slit. The advantage of Femto in this case is when you do an OCT, you can see here that if you zoom in, you can see there is a pre-existing defect. So you are sure there are a lot of kinds of posterior polar cataracts. Some do not have a pre-existing PC defect, and you are able to get away with good phaco. But being prepared is so important that we now know this capsule is ruptured. It is going to give way. So we have increased the posterior offset to get a thick epinuclear sheet to protect us when we are doing phaco. A good CCC is important because this is a place where you will be implanting the IOL, most likely in the sulcus. So this is the overlay of the OCT, the intra-op OCT. You can see here the lens dropping. Can you see the lens? So this was pre-operatively case which has a rent. So this can easily be phaco-emulsified. You see here, because the epinucleus is so thick, even though the PC has given way, you still are able to get away with nucleotomy. Most important highlight is, of course, to do a hydro. This is already pneumodissected. So you don't even need to do no hydro maneuvers, just remove. So, and of course, put in viscoelastic before withdrawing the probe. Now, I'll show you the mistake we did. We have put in a single piece IOL in the back. It's a vertical slit. We thought we'll get away with it because we'll orient the haptics in the opposite direction. But you see here that this, you see that this is deforming. It's a rather large rent. Why we actually went ahead with this is because, sorry, I'll just show you the. There is an overlay. This we thought was an intact vitreous phase because you see here, but this OCT intra-op, when you look at, there was vitreous herniating out. So it actually was not a suitable case to put a single piece IOL in the bag. So even when you do a simple hydro dissection, that pressure can sometimes make the bag more unstable. A single piece IOL in the bag, now tilting. What do? We have to retrieve it. There are two ways to retrieve it. I think a posterior levitation is a very useful technique. You can actually go in with a blunt instrument from the pars plana, but here we have to do a lot of maneuvers to just bring the lens up. We just make a halfway cut through a scissors. This allows us to engage the lens and through a small incision, just cartwheel it out. Now you have to do a thorough vitrectomy. And remember, do not place a single piece IOL in the sulcus because it has thick square haptics, and that will rub against the back side of the iris and give pigment dispersion, inflammation and glaucoma. So we've now used iris hooks to actually visualize if we have an intact rhexis, which obviously we have a good rhexis. That's the advantage of a Femto. But you must visualize. Even if you have good technology, don't give up on your basics. Must visualize and put the 3-piece IOL back in the sulcus. And this was the end of the surgery. So all in all, Femto is a great tool and technology, but surgical expertise and getting the basics right is still the prerequisite. Thank you for your attention.
Thank you, Dr. Ritika, for your excellent presentation. I want to ask you, in the last case that you have shown beautifully managed very nicely, is there any indication of doing pars plana vitrectomy in this case also, or it was done on anterior route only?
No, sir, you can do a good pars plana vitrectomy. The reason we did not, because we thought that the vitreous face is intact, and we'll just put a single piece. That's what I said. So having a beautiful, having a pars plana approach helps us even levitate the IOL, the way it was dangling. So we've actually grown very fond of the pars plana. It's very safe. And when you put in a cannula, it's actually slightly away from the retinal surface. So you don't, whenever you enter through a trocar cannula system, you're actually not risking retinal tears at the time of entry and exit. So it is quite safe for an anterior segment surgeon also to do now.
Thank you very much.
Yes, sir. Was ideal, yes, sir. Yes, sir. So that is what we tried to do.
Yeah, we are also stuck up in such situations sometimes.
Yes.
It is not only you are stuck up, we are also.
So that is what we thought. I wanted to show this unedited on purpose because sometimes things don't go as per your plan and you can't always deliver the best, but you should deliver the best for the patient and recognize the mistake and revert back to plan B. So that's the reason we thought we'll do the single. That's how we put it, sir. But that because of the hydro and there was some vitreous which was not recognized, we skipped the triamcinolone step. So that is the reason.
Even previous case, you say it is very easy. That was not so easy. Subluxating cataract. It was not
No, no,
very
no.
easy that way.
But it was easier, sir, because the nucleotomy is done.
Yeah,
That was relatively, it was not easy because this was a very large amount of subluxation. But having a femto, even rexes in this case would have been very difficult because there was no counter traction, so it made life a little easy. Thank you.
Thank you, Dr. Ritika, once again.